Welcome and thank you for coming out. It's great to see so many people interested. So as Bryn said, this is an exciting juncture for us. White paper launched at the Royal Society of Medicine on the 4th of October, so a couple of weeks ago. And this is probably the first of many events that we're going to be holding around the country. And if the level of interest is anything like it is here in Nottingham, I think we're just going to be overwhelmed. It's absolutely fantastic to see, and the positivity just gives me a little goosebumps down my spine. It's so exciting. So what I'm going to do is go through some of the key elements of the white paper. You have them in front of you. Please don't point out where I get things wrong, because I may, but there we go. But the crux of the whole white paper is to set out a line in the sand of saying how could and should human factors ergonomics be implemented in health and social care. We very intentionally said health and social care, both to recognise that a lot of care is delivered formally and informally outside of the acute sector, but also that there continues to be political strategy to move more care in that direction. And human factors ergonomics has a lot to offer in that area as well. So it's the authoritative guide. The Chartered Institute of Ergonomics Human Factors has its royal charter from the Queen, the Privy Council, recognised as being the only professional body which provides this type of support for human factors ergonomics in the UK. So we are both the professional body and the regulator. And I'm currently the co-chair of our Professional Affairs Board. I co-chair with a colleague from BAE Systems. So we have an academic and we have a professional practitioner leading our Professional Affairs Board to ensure that we cover the spectrum of human factors activities. So what we do in the white paper is just really clarify competence, experience needed to try and bring in human factors ergonomics within health and social care. I suppose the first thing I should say is you'll notice that I use the terms human factors and ergonomics interchangeably. We do this throughout the world. We have a very large international ergonomics association. And in fact, human factors as a term is pretty much only used in the English-speaking countries. Pretty much everywhere else in the world, they use the term ergonomics. So you'll find that the English-speaking countries, most of our professional societies, institutes, are called Human Factors Ergonomics Institute, Society, whatever. And so just to make that clear. So what we're aiming to do, our vision within this white paper, is to build on what's already there. And there is quite a bit already there in health and social care, but it's recognising it and bringing that forward. Broaden the scope, guide understandings and shared aims and offerings. So where people are already doing human factors ergonomics, to say, that's fantastic, let's keep going. Let's look at, is this human factors ergonomics perhaps which we would say in the broader sense, or is this one area and there are more opportunities to bring in wider aspects of human factors? But fundamentally, and you'll find in our international definitions, it's all about optimising human performance and human well-being, and system performance. Now, health and social care is a little more complicated than some of the other sectors that we'd work in: air, oil and gas, nuclear, defence, rail, whatever, because we very clearly have patients and caregivers, staff as well, and that makes it all just a little bit more complicated, but more fun, more of a challenge, I would say. So we want to raise the awareness of the discipline, and that's clearly what this sort of event is about. And rather than go through each individual point, you can read that, but let me just point out, what we really see our role is to champion this accessible, user-focused approach. Now, the user is any human. It could be a patient, it could be a member of staff, it could be a family, it could be a maintenance contractor. It's whoever the human being is trying to do that activity in that part of the system at that time. So by understanding what the human roles are in different parts of the system, that's where our user focus can be clearly made. So we're trying to develop and embed sustainable system-level improvements. This is a diagram that you'll see. One of the challenges we often have as a discipline is saying, what is human factors? Well, we are a multidisciplinary science. I led our postgraduate programmes at Loughborough University for quite a while. And a lot of our students would come to us with a first degree in any of these disciplines. We have designers, social scientists, engineers. This year, our postgraduate intake, a third of them have got healthcare backgrounds. From right across the medicine, nursing, OT, pharmacy, we have people, we've had dentists, we've had people from a very wide range of different paramedics. I think we've got some mental health nurses as well this year. So we do get people with a wide range. We always have some psychologists, and we quite often have some sociologists. We've had computer scientists as well. So all of these disciplines provide a basis for then going further within human factors. The fundamental two words I always say as take home are systems and design. So our systems are looking at how people, technologies, products, physical spaces, all these interactions, even just the temperature of this room and the proximity in which you're sitting to each other, that's part of a system. And we think about the design, how that's currently designed, what opportunities for changing that design might be, and how the whole system can be put together in terms of the impact. So if you drop a ripple, if you change the design at one point, how does that impact on other parts of the system? Within the white paper, we set out 3 specific roles. The first is investigating incidents, and I'm going to use an example from HSIB. They currently are employing some of our alumni to work there, which is fantastic. They currently have chartered ergonomists within HSIB and are growing their capacity in this area. So we're going to see more and more of how that works. Thinking about systems, understanding what happens. Recently I was in the emergency department in Leicester looking at the frailty pathway. What's the experience from the patient point of view as they move through that system? So the wider system could be something going from very small, me trying to operate the controls here, that's a micro system, to something wider, which could be a sustainable transformable pathway even. And then thinking about design. Where would you expect to see human factors input? And we have some very good examples from some of the other industrial sectors. Defence, for example, has very clearly mapped out and tested where human factors can have the most input in terms of a project or the life cycle of a planning event. So let's start off with just thinking about an example here. Component size mismatch in total hip arthroplasty. This is a never event. It just should never happen. The reason I'm using this example is because HSIB produced a report on it this year. And the first point on the investigation identified human factors which may hinder the identification and verification of the correct prosthesis. That's fundamental. You're not getting the right pieces together. So what does that mean? Now, I suspect many of you in the room probably know a lot more about this than me, but I had a student doing a project on this 3 years ago and came back, educated me a lot. 4 components to a hip replacement. We've got our acetabular cup, we've got a liner, we've got a head, and we've got a stem for the femoral components. And what happens with a component size mismatch is that we can have a head too large or too small, a modular junction that doesn't work. And when the student came back and said, look, this is just an example of a workstation from which people are selecting some of these components, there is potential for someone to pick up the wrong component. The example they give within the report is about Juan, 68-year-old man, total hip replacement. This was a very safe hospital. Team worked together, good team stability, strong supporters of 5 steps to safer surgery. They have safety briefings. You know, we're not talking about a poorly performing hospital. This was a good hospital. However, when we break down the task and look what they were actually trying to do, the individual component, the head, has got 2 measurements for the diameter and the length. And they're selecting from a rack. What happened was the circulating practitioner confirmed something, the length as +5, but didn't read out the diameter. The surgeon assumed the other measurement, so the diameter was the +5, and what we had here was the socket and the head were different diameters. Operation completed, information attached to the surgical notes. So how would we, as human factors practitioners, look at this? The first thing we always do is to unpack. We always try and understand what went on, whether it's an environment design, whether it's a task, whether it's procedures that someone's trying to follow. And hierarchical task analysis is an example of a method that we would use. So what we've got here is the detail going through the different steps from ordering the implant, operating room prep, actually during the operation and then after it. So we've got our definitive implant and the different steps. And what I just want to illustrate here are the different stages where there are opportunities for getting it wrong. And if we have different checking systems or levels of duplication, so we don't have a system that runs through like a golden thread, we then have latent error opportunities at each of these stages. For Juan, the error came to light 12 months later. Discomfort and looseness of the joint. The surgeon noticed the implant sticker showed that the diameters of the socket and head were not compatible. And what I really want to point out, it's not only Juan who was affected by this incident. It's the whole team. They were devastated that their error had caused harm. And I know from having been a clinician myself, to realise that you've done something completely inadvertently that causes harm is a dreadful, dreadful feeling. You're not there. You're there to help people. So if somehow something has gone wrong in the system which has contributed to you making a mistake when you were really trying not to, it's a terrible feeling. So HSIB makes the following safety observations. And one of the things they identify is that the National Serious Incident Reporting System currently does not ask about the context. What happened? What were the environmental conditions? And my student came back with this great picture. And the circle around the back is actually members of staff trying to read things. You could say that lighting's a little bit dim for that. And we know we have an ageing workforce. I've just had cataract surgery this year. If I'd have been standing in front of you here 12 months ago, I would have been struggling to read, and I certainly wouldn't have been driving back in the dark. However, now I can. You know, we have staff who have differing abilities for how their eyes work. And so to ask them to work in an environment where the lighting is poor introduces an error potential for reading and transferring information. And that's just one of the environmental factors that a human factors analysis would consider. This is another one, labelling of prostheses, where the information is. And at the moment, we don't have standardisation. So if you go to your boxes of different options, components, the information can be in different places, which if you're doing it quickly and moving between different suppliers, introduces another latent error where you may make a mistake. So in order to try and increase the human factors input in health and social care, clearly we need more capacity. So what we want to see is human factors included in clinical curricula. I have a colleague who works in the School of Pharmacy at Robert Gordon University in Aberdeen, and she's currently just taught hierarchical task analysis to 150 undergraduate pharmacists. I'm in awe. I think she's done an amazing job. But what's enabled them to do is to look critically at things that they do, and they probably end up applying that approach in lots of different areas of their practice. Our challenge here is that every health and social care organisation would have an identified human factors advisor. Now, what I mean by that is someone who has a qualification which is a minimum of a postgraduate certificate. That's a third of an MSc, it's 60 credits. And I expect people to go, oh, that's not a good idea. But I was doing this presentation elsewhere, and someone who's part of the transfusion service, SHOT, said, actually, no, that's the requirement we have for blood transfusion. So that every organisation that does blood transfusion would have that. And I said, well, actually, infection control, pretty similar. Tissue viability, well, yeah, actually, we'd expect that. So it's not an unreasonable thing to expect. And we're seeing, as I said, our intake this year, a third of our intake was people with a healthcare background. So clearly there is the interest. What we do know is that if you have your human factors expertise embedded within your organisation, it has much more impact. The person's there, they're familiar with your processes, you get to know people, you can get to meetings at the right time. And as Bryn said, I actually worked as the ergonomist at Nottingham City Hospital for 8 years in the 90s and noughties. And I know one of the jobs I had was to manage the risk assessment process across the trust. And we had a manager of the haematology department who every year I would go visit him and say, how are we going, Brian? How's things? And he said, no problems, no risks here. Okie doke, see you next year. And that carried on. And then Brian retired, and the new manager went, Sue, come and see what we do. And I'm, okay, let's have a look. And so sometimes you just have to, work with the people around you, seize your opportunities, and go where you can to help. And that's, I think, part and parcel of every organisation. But if you're embedded, then clearly you are able to react and support in different ways. We have 2 special interest groups at our Chartered Institute. The Pharma Special Interest Group is interesting. It's led by Brian Edwards, who is from Pharmacovigilance and Patient Safety, and basically the regulators. So they are working with the large pharma global companies to look at things like standardisation, drug labelling, and in fact the testing procedures and how the usability tests in drug trials. So we've got one aspect of human factors coming in from really quite a long way upstream before any of these products would get to you. And they have identified all the different areas that they want to work with, from regulators to buyers to dispensing, whether that's hospital or over the on the high street, and obviously in the industrial sectors as well. And this really ties in with initiatives that we're seeing coming through. Human factors in health and social care is not new. WHO back in 2002 said we need to strengthen the science basis. What we need to do, I would say, is not reinvent the wheel. There's a lot of human factors science that's out there. It's been applied in other industries. Let's bring it into health and social care. And there's a lot that we can use and modify and adapt, but the basic frameworks are there. A lot of you will know about the National Quality Board, Concordat, and that was exciting because it linked human factors and quality improvement, as did the health education priorities from 2016, so forward planning for the next 15 years. And what they said was that human factors approaches should underpin current patient safety and quality improvement science. It gives us this coherent system for taking things forward. And I'm not going to dwell on that now, but if that's something that you're interested in talking about more, that's something that I think is an area where we can do a huge amount. And bang up to date, Tokyo Declaration on Patient Safety 2018, there was a pledge led by Jeremy Hunt at the time. Yeah, that was a very well-behaved reaction. To support and enable implementation of changes in systems. And we are going to have a World Patient Safety Day, 17th of September every year. So something to look forward to. What we've got, though, is this continuous support for saying, yes, we need to do it, and yes, let's move forward. And I'm delighted to say that the white paper has gone international. We have people taking it initially in the English-speaking countries, South Africa, Australia, New Zealand, US, but one of our colleagues is now in Mexico working on patient safety initiatives there. So, we're starting to see that whole movement going forward. You'll see within the white paper that we set out how your strategies could help to getting human factors embedded. And what I mentioned earlier about the example from defence, well, this is it. This is from DSTL. So what we've got here is the cost of managing when things go wrong. Cost of detecting and resolving human performance issues at different stages in the life cycle. So, if we employ our human factors consultants early in the life cycle, clearly there's a cost. If we don't, clearly there's no cost. If we then continue through the life cycle and we have no human factors involvement, the cost of human performance going wrong grows and grows. If we have some reactive human factors, there's less of a cost because what we do is we put in mitigations, we put on sticking plasters, we try and change things where we can. However, if we plan our systems, so if we're talking about defence, this is about, it could be about designing submarines, it could be about designing tanks, it could be looking at the uniforms that they're wearing, it could be looking at the visors and the computer interfaces, any of those things. If they get their human factors involvement up front, What they have found, and this is from over 35 years of having national human factors teams working within defence across air, land and sea, it's cheaper. You put your cost in up front and overall you save money. And surely that's got to be a good thing. So the suggestion is that to give human factors the best chance is by formalising the process. Just standardise what it is you do. That way, and particularly in procurement, and defence have actually been incredibly successful. They now have joint service publications across land, air and sea to make it mandatory that in any procurement they have to have human factors sign off for whatever it is they're procuring. And that was 2016 that came through. So that's really very powerful. Because if we don't have that, and we don't have this design-led proactive approach, what we see is odd things. And what we have here are people who were working, welding, and they weren't given visors. So what they did was they made their own visors. They protected their face. It's not ideal, particularly the ones made of paper. But, they took... When you see people doing funny things, you see how people have modified what they do. A human factors person would never go in and say, oh, actually, you need to change that. We go and say, oh, why did you change that? That's interesting. Because what people have done is been creative and they've designed a coping strategy for something that they're finding difficult to do. So if we get these workarounds, then let's explore them. What I'm now spending quite a bit of my time doing is looking at policies and procedures, even from NICE policies and procedures. And we would call that work as imagined or work as prescribed, what you're supposed to do. And then you either look at how the local trust has adapted that to make it relevant to what they do locally, or you go in and watch what people do to look at work as done. And what that ends up is that, for example, I've been looking at maternity, women giving birth post 37 week for a normal delivery, and we've got different procedures, protocols in place in different hospitals, so potentially women will have a different experience depending on which hospital you go to. But there is central NICE guidance, so everybody's done a little bit of Chinese whispers in modifying it to their local situation. And what we're then seeing is work as done, which is introducing a level of variance, some of which may be okay, some of which may not be okay. And finally, we've got this create inclusive solution. So this is about making sure that all the people in the system are accounted for and included whenever you design a solution. So when human factors is done well, what good looks like, it supports whatever it is you're trying to do to help you to succeed. So if we put in a cupboard where we know the anthropometry, the shape and size, the physical shape and size, means that some of the workforce are not going to be able to read the labels or possibly even reach that shelf, then we're building in conditions for things going wrong, picking the wrong thing out or possibly dropping something as they try to take it out of that cabinet. And if they do it over and over, possibly injuring themselves. Then maybe being off work, then we have a staffing problem, and we've got a ripple effect from that cupboard being put in at the wrong height. So what we want to do is design out the potential for those sorts of situations. When human factors is done well, you then don't need to tell people how to do something. You know what it's like whenever you get something new and you can't intuitively work out how to use it, you have to read the instructions? I would say that's not the best design it could be. If it was the best design it could be, we all know that we're rubbish at reading instructions. And that's why if you buy a new car, they don't expect you to read the manual. They have a quick, guide, or if they've got it on a central screen now, there's only buttons you can press in order to do certain things. Anything which builds in the system that recognises our capabilities and our limitations as human beings, that's good design. What are we good at? What are we not good at? We're not good at having lots of different terminology for the same thing. I was examining a PhD this morning, And the PhD described, this is a bugbear of mine, she described the participants as participants, interviewees, candidates and staff. I said, no, they are participants all the way through. And we need to get this standardisation of information because it reduces the opportunities. Or where we do have variance, there has to be a reason for it. So let's not just do it because, you know, it's something which somebody thought up. Try not to involve reinventing the wheel. And enabling, making sure it's designed so that everybody can understand what it is we're trying to do. And in doing this, we can then build our value. So our economic value should be the value in the people, that we get better care outcomes, we get better experiences, that we get better active value, that we eliminate fragmentation and duplication, that we get better technical value, we have better quality of care and safer care. And that all should help us to save money by not duplicating things, by not having errors, by reducing inappropriate care. It's a big ask, but we do have really good examples from other industrial sectors who spent the last 35, 40 years doing that. It's not going to happen overnight, but it is possible. At the end of the white paper, you'll find a series of case studies, and I'm going to go through a couple of them with you in a couple of minutes. But what I want to do first is, because you're not in London and we don't have the benefit of having Paul Bowie here from Scotland, is just share with you what's happening in Scotland. They are a smaller country than England. They only have 7 health regions, so from that point of view. But you could say this is something which is easily achievable on a regional basis in England. So they've been working on human factors, led by Paul, for the last couple of years. They have over 150 clinicians, leaders, managers, educators, improvement advisors, from all these different trust boards, NHS boards, universities, and other sectors. And what they're really doing is building capacity. They have a national advisory board, only just, but they do. They're building capability and capacity, they're learning from events, they're integrating design programs into national initiatives. And they have this integrated R&D evaluation agenda. It's all really exciting. And this is their vision. And I'm delighted to say that they are going for this minimum of one qualified HFE practitioner at each NHS board level. That's the equivalent of each trust. But you can see that they are trying to do undergraduate, postgraduate, CPD, simulation, improvement programs, inductions, board members, management training, right across. They're really doing us. Let's try and infiltrate and make sure people are understanding and speaking the same language. And they've got really nice examples of how you can look at postgraduate. This was actually, I think it was GP training, and working with the Royal College in Scotland to work out how you can have different aspects of human factors embedded at different stages of training. But Paul also was pretty reflective. He said, what's happened? Hard truths. He does think they've scratched the surface, they're making progress, but, you know, they're constantly having to reflect and review and think about how it's going. His words, quality improvement is king. I see that as an opportunity. I see it as there's a lot of quality improvement, and I think human factors and quality improvement works really, really well together. But in Scotland, they have had an interesting, difficult situation. Because non-technical skills was called human factors and led by academics, oil and gas, aviation, in Scotland, it's been quite hard to do that. And so what they've done is take a hard line, and Paul's hard line was to say that he would only work with human factors professionals who were chartered ergonomists, so that he knew he was getting the real deal, that what he paid his money for, he got the experts. He said it was pretty tough and it was a hard thing to do, but it's paid off. So now they're getting involved working with WHO, which is really great, and building this community, academic and medical royal colleges, and actually getting things embedded within the various colleges. So as I said, we have a copy of the white paper. If you want to download and share electronically, you're very welcome to do that. Within our Chartered Institute, we can try and link you up with people locally. Obviously, Bryn has an excellent resource here. And Alexander Lang, Dominic Furness are the contact people for the special interest groups. And that's, I think, all I'm going to say at this stage.